to him.
Well, thanks for the kind introduction, Dr. Morello. I appreciate that. And also highlighting Women's International Day. That's excellent as well. So it's great to be able to speak to you folks in Calgary. Unfortunately, I'm not there and we'll have to do it virtually through Zoom. And so I just wanted to highlight the importance of this emerging field, cardio-oncology, and particularly my interest in it. As you can understand, that I have a background in pharmacology and now have an evolving interest in echocardiography. So the cardio-oncology definitely aligns well with my interests and aptitude. I've also married an oncology pharmacist strategically to keep abreast of pharmacotherapy as it relates to cancer too, which can help me with the alphabet soup of the protocols in cancer care. And so with that, we'll just get to work here. So the objectives today, we will discuss briefly the epidemiology of cancer, as well as the importance for the inception of cardio-oncology. And with that, I'd like to overview some cardio-oncology cases that highlight the actual manifest LV dysfunction. And from there, highlight the importance of subclinical cardiac dysfunction assessment and some of the challenges that we experience with that. I won't focus as much on LV strain, given that Dr. Sher Crosby did a fantastic job emphasizing the role of LV strain, but I'll highlight some of the areas outside of strain that enhance reproducibility, as well as I'll highlight some of the research that I'm undertaking in Edmonton. I also want to make sure that we're all aware of the importance of collaboration in cardio-oncology, and I think that's certainly right in Calgary with the Calgary Cancer Center, as well as the deployment of EPIC. And so I have no disclosures. And so getting right into it, 229,000 Canadians will have been diagnosed with cancer in 2021. And it's genderly non-specific, okay? And so about 2 in 5 people will have a diagnosis of cancer based off of current prevalence. What I want to highlight here is in the blue, at 64% was the 5-year cancer survival here. These are Canadian statistics. Importantly, 5-year cancer survival in the 1990s was 55%. So you can see that with the advancement of cancer care, we've seen an increased cancer survivability over the time. This is, I think, a nice slide that highlights what's called the silver tsunami. And so you can see by age stratification and estimated prevalence that a significant amount of people are surviving cancer and will so with greater incidence over time. And so what you're seeing is a large and significant proportion of people that are octogenarians that carry other comorbidities despite their cancer, specifically in the realm of cardiovascular disease. And so if you look at deaths related to, or mortality related to individuals with a cancer diagnosis, over time, the index cancer related deaths have decreased, and that's related to immunotherapies, advancements in cancer therapy and radiation over time. But what you're seeing is there's a non-cancer related increased mortality in these patients. So the question is, why are people dying not from their index cancer? And so the answer is it's cardiovascular disease. And so you can see highlighted in the red here, which is cardiovascular disease. And so after the time of diagnosis followed prospectively, these individuals are found to have a greater mortality related to cardiovascular death and burden. And so if you age stratify these individuals, you can see that as they age, cardiovascular disease increases over time, resulting in death in the patients that do not have an index cancer death. And so what are the reasons for this? So why is there an intersection between cardiovascular disease and cancer? And it's multifactorial, but one of the new evolving theories is related to CHIP. And CHIP is clonal hematopoiesis of indeterminate potential. And so there's certain genomes or genotypes that are associated with it, like JAK2, TET2, and several others. And so as people age, these genotypes are expressed and clonal hematopoiesis occurs. And with that, you get a proliferation of inflammatory cytokines, particularly IL-1 and IL-6. We know as cardiologists that these increase the inflammasome and plaque vulnerability over time and cause increased risk of atherosclerotic disease, as well as accelerated atherosclerosis and plaque rupture. But how it relates to cancer, as well as cardiovascular disease, it results in increased tumor progression and increased reactive oxygen species, which can also predispose to arrhythmogenesis. If you combine that with some of the immunotherapies that are being offered and advancements in chemotherapy, it really develops a milieu for an intersection of both cardiovascular disease as well as cancer burden in the population. And you combine that with some of the evolving immunotherapies over time that we're just getting introduced to, is really the checkpoint inhibitors, CD4, CD6 inhibitors like ribociclib has also been known to cause increased QT prolongation. And now we have CAR T-cell therapies, which are starting to get an understanding of their cardiovascular implications. And so what we're seeing is with them, with cytokine release syndrome with an associated troponin burden in patients with a cytokine release syndrome greater than 2, in terms of their grading, there's about a 55% chance of adverse effects from a cardiovascular perspective that occurs. So it's really mindful that we keep tabs on some of these immunotherapies. In terms of why that's important too is ongoing surveillance. And so this is a nice slide that was in the Heart Failure Journal of JACC, and it describes the onset of clinical use and the latency in terms of cardiotoxicity recognized, and then the latency of surveillance of EF monitoring in patients. And so in the early 1960s, that's when the anthracyclines were incorporated into clinical practice. And 1967 was actually the first clinical case report of anthracycline cardiac toxicity. And then subsequent to that, it took about 10 years before surveillance started occurring for EF monitoring. And you can see the subsequent latency periods evolving as well with some of the newer therapies over time, most specifically the immune checkpoint inhibitors. And so in terms of cardio-oncology, over time as well, there's been an increasing interest and understanding of those pathobiological mechanisms, as well as chemo and immunotherapies causing cardiotoxicity, as well as understanding that cancer survivorship manifests in increased cardiovascular burden. So we see that over time as well. And as a result of increased publications in that sector and the cardio-oncology arena, JACC has actually recently published its first issue of JACC Cardio-Oncology in 2019. And so how I see cardio-oncology is a bridge between hematology, oncology, as well as cardiology. And that alliance, I think, is exceptionally important in the future. So just changing gears here a bit, cardiotoxicity is something I want to talk about in greater detail. And so important to understand that cardiotoxicity is not synonymous with cardiac dysfunction. Okay, and so cardiac dysfunction is what we anticipate seeing with anthracyclines, HER2 therapies, which causes like a type 1 or type 2 irreversible as well as reversible cardiac dysfunction. But cardiotoxicity is actually an umbrella term that encompasses myocarditis, which is considered the type 3 cardiotoxicity in terms of implications on cardiac dysfunction, as well as vascular toxicity, which actually includes arterial thrombosis, vascular thrombosis, pulmonary embolism, as well as pulmonary hypertension, which we're seeing with particularly dasatinib and panitinib therapies, which are BCR-ABL inhibitors. It also includes pulmonary veno-occlusive disease, which we've seen in cyclophosphamide as well. The prevalence or incidence of hypertension is becoming exceptionally high, particularly in the VEGF inhibitor population. Bevacizumab, sorafenib, and sunitinib are the therapies that we should be mindful of in terms of that, and really getting a good understanding of baseline hypertension before patients start incorporating those therapies. Arrhythmias is important as well. We see in ibrutinib, which is a BTK inhibitor, about a 16% incidence of new onset atrial fibrillation over a 3-year time period. We have multiple therapies associated with QT prolongation, particularly TKI inhibitors and ATO for APML. And so again, highlighting the prevalence of this. And so the big 3 players in terms of incidence of cardiotoxicity is related to hypertension, cardiomyopathies, and vascular disease. And our flagship drug for vascular disease has been the 5-FU and capecitabine therapies. And so this is a really nice illustration highlighting some of the different mechanisms and areas of cardiotoxicity that occur, and specifically related to the different types of therapies available. And so now I'm going to focus the rest of the talk here on cancer treatment-related cardiac dysfunction. And so how do we define it? And so there is disparity, or I guess heterogeneity, with each different international society, which actually makes it a bit challenging in terms of research initiatives and standardizing cardioprotective therapy for patients when you have different thresholds for the definition. And so as cardiologists, we've typically been using the ASC as well as the EACBI platform for threshold, which is around the 53% mark, as well as 10% decline is kind of across the board. Most recently, the European Society of Cardiology, as well as the International Cardio-Oncology Society, have published guidelines that suggest that threshold should be lowered to about 50%. And the ICOS group is actually risk stratified patients also by symptomatic status as well, which I believe is a bit more pragmatic. So in terms of risk stratifying, so who should we be worried about? And so this is the group that we should be worried about. It's really individuals that have had high dose anthracyclines, those that have had dual exposure to trastuzumab as well as anthracyclines, and those that have received high doses of chest radiation, as well as those with baseline cardiovascular risk factors, established cardiovascular disease, increased age, female gender as well, and elevated biomarkers at baseline, which may suggest that there's either some subclinical dysfunction, cardiac dysfunction, or maybe suggestive of an active inflammatory process of the myocardium. So what I wanted to go through as well is really to highlight manifest LV dysfunction and the severity and the sequelae that can be related to some chemotherapies, as well as give a pharmacologic mechanistic correlation related to that. And so this is the anthracycline therapies, and I think we're all related. We can all understand the wide spectrum of use of these therapies. And so how anthracyclines cause cardiotoxicity is multifactorial, but the main reason why it's thought and felt to cause cardiotoxicity is related to non-specific inhibition of topoisomerase 2A as well as 2B. And so selectivity-wise, topoisomerase 2A is what they're trying to use the anthracyclines for, to halt tumor progression and cause DNA manipulation as well. But topoisomerase 2B is what's found in cardiac myocytes. And so disruption of topoisomerase 2B can cause mitochondrial dysfunction as well as cell death. There's also a quinone moiety on the anthracycline, which can increase reactivity with iron, causing reactive oxygen species and reactive nitrogen species as well. And so it's multifactorial, the reasons why anthracycline can cause the irreversible dose-dependent cardiotoxicity that we see. So this is a case of a 36-year-old with no baseline cardiovascular risk factors that received doxorubicin at 270 based off of the pediatric oncology group protocol. And so it was back in 2002 that he was diagnosed with ALL and started on this therapy. You can see based off of his risk profile, it's probably moderate to high based off of his doxorubicin dose that he accumulated. And so this is an echocardiogram here. Across the top is the apical 4, 2, and 3, and you can see the global longitudinal strain at the bottom. So he comes in with heart failure and is found to have an EF around 22%. You can see a well-opacified LV using contrast affinity with globally reduced LV systolic dysfunction. And the bottom is well delineated, contoured GLS with normal sinus rhythm, with a compromised GLS, as you can see, around the 8% mark. And I'll highlight some of the values that we look for in GLS and strain. And so this is the number that he got, was a GLS of -8, and acknowledging that about less than 17 based off of Thomas Orwick's data is suggestive of cardiac dysfunction. And so this is his right ventricle, which is often the neglected right ventricle, the neglected ventricle. And so you can see this is an apical 4 chamber with the right ventricle in focus here. with an X-plane through, demonstrating there's hypokinesis of his right ventricle. Quantitative parameters, the tricuspid valve S prime, as well as his TAPSE were further reduced as well. And so what about HER2 inhibitors? And so they're considered the type 2 reversible cardiotoxicity associated with it. And so they're used for overexpressed breast cancer as well as metastatic gastric cancer. So the mechanism of cardiotoxicity is related to inhibition of neuregulin 1, which has downstream effects on HER2. And HER2 actually has a cardioprotective effect during times of stress. And so when you dysregulate HER2, you actually cause cardiomyocyte dysfunction, as well as you can get a double hit process, specifically in combination with anthracyclines. And so it potentiates the risk profile quite significantly in breast cancer patients. So this is a 57-year-old lady with a history of stage 2A left multifocal invasive ductal carcinoma that's HER2 positive. She had 15 cycles of TCH, which is a Herceptin-based protocol. So no baseline risk factors for her. And you can see across the top that this is her baseline. And then 3 months later, with her Herceptin therapy, there are differences that are appreciated. I think most notably, you can see the anterolateral wall in the apical floor chamber is less robust in its contractility relative to its baseline here. And so her EF at the beginning on her baseline with surveillance was around 63%, followed by 46% after three months of her trastuzumab therapy. And so this is really nice, again, GLS deformation contouring that we see. And you can see across the top, these are actually normal strain values being greater than 18. And down below here, this is after 3 months, apical 4, 2, and 3, that her GLS is now decreased to around 17 mark. But if you look, if you actually look at her in terms of the relative change, it's around 18%. So it actually meets the GLS criteria of greater than 15% for cardiac dysfunction. So next I wanted to talk about immune checkpoint inhibitors. And so their use is rapidly evolving. And so we're seeing that in terms of increased utilization since 2004, once they really hit prime time. So the mechanism of cardiotoxicity is related. It's first important to actually highlight how they work. And so in the blue here is a tumor cell. And what it can express are ligands that are checkpoints that actually inhibit T cell CD8 activation. And so with inhibiting T cell activation, you actually preserve the tumor's functionality as well as increase tumor proliferation by the tumor cell's ability to produce these proteins and ligands. What checkpoints they do produce are the PD-L1, which is a programmed cell death ligand 1, and PD-1, as well as cytotoxic T lymphocyte antigen protein 4. And so what happens when you use checkpoint inhibitors is you actually disinhibit the T cell, increasing their activity and cytotoxicity to cancer cells. The problem with the use of them is that you can get a widespread hyperimmune response causing an inflammatory process, an autoimmune injury. And so with injured cardiac myocytes, you get PD-L1 expression, and you can actually get cytotoxicity resulting in cardiomyocytes. And so what we've seen is acute lymphocytic myocarditis, which can be quite severe in patients with an estimated 25 to 50% mortality based off of recent studies. So here's a case of a 67-year-old with metastatic papillary renal cell carcinoma that had pembrolizumab therapy with a baseline history of hypertension and OSA. So he was admitted with heart failure, elevated BNP and non-sustained VT, and had a normal baseline echo that was reported, which I didn't unfortunately have. So he comes in with cardiogenic shock, elevated heart BNP and heart failure, and had some episodes of non-sustained VT. So these are non-contrast images of the parasternal long and short axis. And you can see the contrast images delineating severe global LV dysfunction with an EF of around 20%. So his EF improved to around 35% on standard guideline-directed heart failure therapy. He did require an ICD for his non-sustained VT. And so what I wanted to highlight there was really manifest LV dysfunction. And so just to demonstrate what the importance of echocardiography is in terms of surveillance, and really highlighting the importance of using echo for subclinical cardiac dysfunction assessment. And I also wanted to talk about how we can enhance reproducibility in some of the research that I'm involved in. And so why do we use echo? So for cardio-oncology, we use it because it's accessible, it's inexpensive, it's versatile, it's actionable in terms of guiding therapy, it lacks radiation, and it's safe in kidney patients. And so it's been validated in use as the first line imaging modality by various cardiovascular societies, as well as ESMO and ASCO as well. And so this is typically what we are trying to achieve in terms of our echo assessment, and that's all highlighted here. What's important is highlighting the importance here of RV assessment. And so once again, I did highlight the RV is neglected. There's a recent paper published in JACC using 3D RV echo that demonstrated 36% of patients met the criteria for a decreased RVF in patients treated for diffuse large B-cell lymphoma. So it is important to highlight the importance of that, as well as there are certain therapies like dasatinib and palatinib, or panitinib, sorry, that can increase their susceptibility for pulmonary hypertension. So I think it's important to have those baseline characteristics assessed and surveillance performed on subpopulations of patients at risk for RV dysfunction. This is our current surveillance that's required for patients. And there's some equipoise, particularly with the VEGF inhibitors in terms of surveillance, but anthracyclines and HER2 therapies should have ongoing surveillance at baseline and going forward. And the frequency at which is probably dependent on the risk profile. In terms of VEGF inhibitors, the LV dysfunction associated with them is anywhere between 2 to about 15% on the reports that I've actually read. Proteasome inhibitors, there's a recent study called the Endeavor trial, and a sub-study of that demonstrated that there was no benefit in echocardiographic surveillance, despite carfilzomib having quite a significant amount of cardiovascular events associated with it relative to bortezomib therapy in multiple myeloma. Immune checkpoint inhibitors, the data is still out on terms of surveillance. I think biomarkers might actually be a bit more of an important role than on baseline surveillance in these patients, acknowledging that in the context of patients that are symptomatic or high risk, perhaps that may warrant baseline echo. So subclinical cardiac dysfunction, we use LV strain. And so I don't want to go too much into LV strain because Dr. Sherrard-Crosby just talked about that. But for those that didn't attend, global LV strain in general is tracking deformation of the myocardium. And so that can be done with longitudinal or radial or circumferential shortening. And so what we look at is actually the final length minus the initial myocardial length. And so we actually get a negative number when we calculate that value. And again, highlighting an abnormal value is less than 17, and that's also vendor specific. And it's also very important to have a baseline assessment compared to a follow-up assessment, and being able to ensure that you're using the same vendor, because the speckle tracking and thresholds are different and vendor specific. So why we use LV strain is really because with anthracycline therapy specifically, complete recovery of systolic function is unlikely to occur. Okay, and so early detection of toxicity is important. And so this is a study that was performed by Dr. Thomas Marwick, as well as Dinesh Devandaranathan, who's out in Toronto. And is a meta-analysis of 1,500 patients, small numbers of patients in each group. There was heterogeneity associated with it, however, but they demonstrated that GLS did with 10 to 15% early reduction in GLS correlated with the prediction of cardiotoxicity in patients. And so highlighting again, really nice contours as well as a normal sinus rhythm in this patient. And this is that patient that had breast cancer that I highlighted earlier. Why I wanted to show this is that when you have the right image profile and the right patient characteristics, tracking deformation can be quite useful. But I also wanted to highlight pragmatically the challenges with LV strain. And so that's, if you don't have the right quality image, the right contouring that's capable, or that if you don't are unable to do proper tracking or contouring, garbage in is garbage out, unfortunately. So I think the onus is on the cardiologist or echocardiographer to make sure that quality control is maintained when you're doing proper strain, and considering the implications of it in the cardio-oncology patient. It's important to understand strain challenges with changes in Frank Starling. And so thinking about preload, and if you have reduced preload, you have reduced Frank Starling mechanism and contractility. So that's going to cause changes in your deformation characteristics. And so these are patients that are often preload deprived with nausea, vomiting, diarrhea, and anorexia. And so you have to be mindful of that in surveillance monitoring. Patients that have had infarcts have akinesis of segments that can affect deformation, and the chamber geometry can affect GLS as well as mechanical dyssynchrony. What wasn't mentioned in that slide is also if you have variable R to R intervals can change the magnitude and how robust we can rely on GLS performance. So this is the SECURE trial, and it was done by Dr. Thavinduranathan as well. And so it looked at GLS guided cardioprotective therapy initiation compared to LVEF alone, and in high risk patients. And so unfortunately, they did not reach statistical significance on using a GLS guided approach to attenuate LVEF decline by instituting cardioprotective therapy, which was in the form of ramipril and carvedilol that was titrated. Their key secondary endpoint that they wanted to highlight was that they did have a reduction in the definition that they ascribed of CTRCD being a GLS fall from baseline greater than 12%. And that was mitigated with the use of early cardioprotective therapy with a number needed to treat of 13. This was, once again, not their primary endpoint. Importantly, specifically important for the cancer patient is that 5 patients had their chemo interrupted or discontinued in the GLS guided arm, which I think is a challenge because from a cardiology perspective, I think what we're trying to do is mitigate interruption by preserving the health of the myocardium to facilitate the chemotherapy. So that I did find to be challenging when I reviewed the trial. And so how good is cardioprotective therapy? Specifically talking about drug therapy. And so this is probably the most robust that we have in terms of a meta-analysis that combines a lot of the key trials like the Cardinal trial, PRADA, as well as Manticore. And they found that the utilization of neurohormonal protective therapy reduces LVEF decline or attenuates it by about 4%. The big challenge with this meta-analysis, if you can see here, I-squared is 98%, so a significant amount of heterogeneity. Some used echo, some used MRI. There's differing variability in the EF thresholds that were used, different numbers of patients, different drug therapy was used throughout. So a lot of heterogeneity amongst the trials. And so it's really tough to glean much from this meta-analysis. And so when you look specifically at some of the trials individually, Prada and Manticore were quite well done. And Manticore is actually done with Dr. Patterson's group in Edmonton. And they found about a 2% LVEF attenuation with cardioprotective therapy with patients that had subclinical LV dysfunction. And so that's not including some of the other cardioprotective therapy that's out there, and that's highlighting, dexrazoxane, liposomal doxorubicin, or using continuous infusions versus bolus infusions. So there's other mechanisms that we can try to target other than just pharmacologic therapy like neurohormonal therapy. So I wanted to talk briefly as well about reproducibility in echo. And so we are with echo is, I think, here. So we have a favorable degree of accuracy, but precision is lost. And specifically with strain, there's a lot of reproducibility issues with the use of strain, unfortunately. Where we want to be with echo, specifically with the cardio-oncology patient, is to enhance accuracy as well as precision. And we're not there with 2D echo alone. So the problem with 2D echo is low sensitivity. We're making geometric assumptions. There's foreshortening and lots of variability with measurements and challenges with identifying subtle regional wall motion abnormalities. And so when we look at the International Society guidelines, all of them highlight this 10% decline. And so the problem is 2D echo specifically is challenged in that regard due to the fact that our minimal detectable difference is about 10% using standard 2D methods. And that was from, again, another trial that I'm highlighting from Dinesh Devandaranathan. The temporal variability, however, with 3D echo was 6%. And so American Society of Echo, the European Society of Cardiovascular Imaging, and the British Cardio-Oncology Society, and British Society of Echocardiography all highlight the need for 3D echo to enhance reproducibility in our cancer patients. And so this is a 3D versus 2D comparison of CMR. And you can see that in patients with an EF less than 50% identified on CMR, the correlation is greater by using 3D versus 2D methods. And this is published in the American Society of Clinical Oncology. And when we look specifically at the performance characteristics in terms of sensitivity and the false negativity rates, you can see that 3D echo is also superior to 2D echo as well. And what about the use of contrast echo? And so contrast echo is certainly helpful, as you can see in this picture. It helps illuminate and opacify the LV so that we can really get a nice visualization of the blood tissue interface and can see the apex better, which is often foreshortened in non-contrast mediated images. And so Nazmi, I'm not sure if he's on the call right now, had asked an important question during Dr. Scherer Crosby's talk. He highlighted that in technically difficult studies, can we use contrast in patients for GLS tracking? And so this is a study that was actually performed in Edmonton, actually, I'll pass it here, by Dr. Becker and Dr. Jonathan Choi. And so it appears as though there is a correlation, positive correlation with the use of ultrasound enhancing agents in strain. And so that's a modality that can be used. Obviously, vendors have not encouraged the use of it at this time. But it's important that this does demonstrate some degree of correlation with using contrast with strain imaging. And so what do we think of in terms of minimal detectable difference with contrast echocardiography? Again, this was done, a study in 2018 done by Dr. Choi and Dr. Harold Becker here in Edmonton. They found the minimal detectable difference of around 3 to 4% using contrast echocardiography. And so I just wanted to highlight the importance of the trajectory of machine learning, artificial intelligence, and echocardiography. And so this is a study that I'm currently involved in with Harold Becker in Edmonton. And so the utility of AI in echo has been demonstrated already. And so this is a nice study here, 2019, that looked at three expert echocardiographers that did volume-based EF assessments using Simpsons. And they compared that to a machine learning tracking system through a pipeline. It wasn't through Ultronics, but through a different group in San Francisco that demonstrated an R value of 0.95. And that's based off of a pipeline that they've used about 50,000 baseline echoes, but they looked at 99 echoes. The cardiologist looked at it and had a 0.95 R value, which is quite significant. So this is the platform that we use here in our studies. So we're collaborating with Ultronics, who have the Echo Go pipeline, which is the only FDA approved AI echo pipeline for machine learning that's been established. And so we've had the good fortune of working with Ultronics on that. And so this is what happens in a standard format. So what we're doing in the Echo Lab generally is we get a GLS performed or a 3D echo performed, and we look at the images, we contour them, we save the report, generate the report, put the images in, and then that requires a lot of training, a lot of effort. But with machine learning, you can actually outsource a lot of that. And the reproducibility benefit of it is that it actually you remove the human intervention. Okay, and so based off of automation and learning platforms in the pipeline, that's actually done and automated, mitigating the intra and inter-observer variability that reduces our reproducibility in echocardiography. And so what we wanted to do is take that information, our current understanding of AI processes, and see if AI can actually provide similar or equivalence to using contoured contrast images, comparing that to auto-contoured AI echocardiography. And so we looked at 200 patients with breast cancer, lymphoma, myeloma. We looked at their volume assessments as well as their EF baseline, as well as comparing 3 months after commencing cancer therapy. And so what we found is that there is statistically equivalent, specifically in the breast cancer patients. And that's really because we had a larger volume of breast cancer patients relative to our lymphoma and myeloma patients, which did not equal statistical equivalence, really, I think, just based off of the sheer numbers. If you look at like all of the data, it's in favor of statistical equivalence, and that's probably based on the volume of the breast cancer patients that we have. And we determined our statistical equivalence bounds based off of a Thavan-Nathan study on reproducibility from 2013 that was published in the Journal of American Society of Echo. And so if you look at the characteristics of breast cancer from baseline using manual contouring to auto contouring, which is the AI platform, you can see they're statistically equivalent here with a nice uniform normal distribution at baseline as well as with follow-up. One of the things I wanted to highlight, and Dr. Becker and I will be looking into, is why there's a discrepancy in some of these patients of about 15 to 20%, which is a bit challenging, and it's important for us to understand where and why AI doesn't work. As well, we also want to look at clinical outcomes in these patients too, and see which patients actually were referred to cardio-oncology. You also want to look at which patients started on cardioprotective therapy and identify the degree of why heterogeneity did exist in this patient population, comparing echo that were manually contoured to those with automation. So there's still some work on this study to really kind of drill down the clinical utility of it, or I guess a clinical application to it. I wanted to talk briefly about LA strain as well. And so lots of buzz with the left atrial strain. We know this in the setting of diastolic dysfunction, as well as we know about this in regards to prognostication for atrial fibrillation in this Sentinel study done by the Copenhagen Heart Group, which demonstrated in 4,500 patients followed over 5 years with a peak atrial longitudinal strain less than 23%, actually demonstrated a 6.28 increase risk of atrial fibrillation. So how I see that manifesting is probably that it could be incorporated into risk profiling, like a CHAD score using echocardiographic features, particularly left atrial strain. The other way I see it too is I think it's a more robust means of assessing diastolic function, perhaps better than our diastology metrics that we use conventionally with Doppler. When you look at peak, this is actually what left atrial strain looks like. And so the contours are highlighted in the speckle tracking is different colors, and that's highlighted here. And we look at peak atrial longitudinal strain, what we're seeing is, this is actually left atrial compliance. So that's different than what we conventionally look at with left ventricular strain, where we're thinking about deformation and contractility. This is left atrial compliance that we're looking at. And so that has a lot of robust features to it in the literature, as well as the peak atrial contraction strain. And so that's more contractility and deformation that we see. And so the normal values for PALS is greater than 23%. PAX is 6%, and LAX is the left atrial conduit. The conduit strain is about 8%. And so our study is, we've taken 91 patients with transthoracic studies of various different types of cancer that have been exposed to cardiosensitive, potentially cardiotoxic chemotherapy. 84 patients were able to look at their images with good quality to track left atrial strain. This is their baseline data. So we're looking at specifically right now EFs that are normal and LV strain values that are normal. And we've got data that so the vast majority, actually the mean is greater than 23. So they're abnormal. Majority are actually normal in terms of their peak atrial longitudinal strain. The interobserver variability is actually quite great. Adrian and I are the observers here, and we've actually been able to have an interobserver variability of greater than 90%. And so within our study, we were able to find PALS being greater than 23 and 88% of the patients, and those that actually had a low PALS score had baseline diastolic dysfunction. So it correlates very well with diastolic dysfunction. And so we've got lots of data still pending on that, but I think it's an important study to look at, especially long-term, so we can maybe detect if left atrial changes and strain precede any subclinical or manifest LV dysfunction in that patient population. So I just wanted to highlight some of that. I did want to talk about RV strain, 3D RV echo. I've got a talk actually on that specific subject, but unfortunately due to time constraints, I wasn't able to get to that. I also wanted to just review in summary kind of what my thoughts are on echocardiography and based off of the information that I've told you. So echocardiography remains the most widely accepted imaging modality for good reason for surveillance in our cardio-oncology patients. LV strain is important, but I do think that we need more data to really truly demonstrate the clinical utility in our cardio-oncology patients. We do know that LV strain is used in other capacities quite successfully as well, but I think with the SECURE trial and some of the challenges with making sure that the quality of the contouring and deformation, I think it's quite important that we get further data on that. I do think that we need to be very mindful of reproducibility with cardio-oncology, and so utilizing novel applications like 3D echo, using contrast given the reduced minimal detectable difference. And I think machine learning is going to be a significant, is going to play a significant role in echocardiography in the future. So I think it's very important that we as echocardiographers embrace that technology, and we're starting to see automation. Even in the next Philips update, we're going to see a bit more of that. And talking about that update, we may be seeing LA strain, RV strain, and 3D RV echo. And so some of those novel applications are coming. And so it's really important for us to stay on top of it. And so just lastly, I want to talk about collaboration in cardio-oncology and how important that is. And so when we think about the chronological spectrum of the cancer patient, that involves cancer prevention, the diagnosis, treatment planning, cancer treatment, as well as their survivorship phase. And so I do feel strongly that cardiology will have a pivotal role throughout cancer care, throughout a patient's course. And in the cancer prevention standpoint, we do know that there's the risk of cancer. The same risk factors in cancer are the same risk factors in cardiovascular disease. So from a cardiologist perspective, by mitigating cardiovascular risk in those that have modifiable cardiovascular risk, I think it's very important because that can actually reduce cancer risk and burden as well. And it helps overall in terms of is basically cardioprotective therapy as well in patients that do have the diagnosis of cancer. And I think we play a pivotal role in risk stratifying patients when a patient has cancer diagnosis and encouraging surveillance and mitigating cardiovascular risk with optimizing therapies, hypertension, diabetes, dyslipidemia, and actually understanding who is at risk of specific cardiotoxicities and really embracing our understanding of the evolution of immunotherapy and really getting a good understanding there. For cancer treatment, I think being able to collaborate effectively with hematology and oncology, determining in what patient populations that are at risk or have manifest LV dysfunction, can we start using continuous infusions versus bolus with anthracyclines? What's our threshold for using a lot like liposomal doxorubicin or dexrazoxane and therapies like that, that we as cardiologists aren't very comfortable with, but just really getting guidance from our colleagues. And obviously cancer survivorship, always important to monitor for risk factors as well as those with established cardiovascular disease and treating them appropriately for the long haul. I also wanted to highlight the importance and the optimism with the Calgary Cancer Center. So I think that we're in a right position in Calgary to really enhance collaboration. We have the infrastructure in place. We have Epic Cumming, which can automate algorithmic referrals. And so I'm really optimistic about how cancer care and cardio-oncology will align themselves in this new space. I think from an interprovincial level as well, collaborating with Foothills and the Mazankowski Heart Institute, will build a scalable, sustainable, and reduce inequities in care across the province too. So these are my take-home points, but with that, I just wanted to conclude and say that I'm really excited to hopefully have an opportunity to work in Calgary with the Cardio-Oncology group and Echo. I'll take questions.
Thanks, Sudhir. That was great. There's a question from Rob Miller regarding the AI study you presented. He was asking whether the readers were blinding to AI versus tech contours.
Were the readers blinded to AI versus? Oh, yes. So were the readers blinded to AI?
So I'll give you the context. So
yeah, give me the context, Rob.
You know, there's several different groups that are working on this concept of using machine learning or deep learning to interpret echo. So David Yang, who's at CTRCD, has a paper in Nature where he used deep learning to segment out the left ventricle and then provided contours from the deep learning model and separately provided contours from like the text and blinded readers. And in that study, he demonstrated improved reproducibility with deep learning compared to the text.
Okay. So with us, what we've done is the tech has actually done the contouring, the manual contouring, but it was sent off, right? And so it got sent off to the Ultromics group. And so we actually don't know, there's a sonographer that actually, my understanding is a sonographer at the Ultromics end determines which studies can be put through the pipeline and forwarded on. And basically at that point, the EFs were established. And so there's minimal human intervention with the exception of the sonographer taking a look at the studies and determining from a quality standpoint. But unfortunately, we don't have much of that information right now as that was outsourced. I'm not sure if that answers your question or not.
Yeah, it sort of does. So I would just say that maybe it highlights that if you still have an interpreter at any point in your pipeline, then you lose this improvement in reproducibility.
Yeah,
great
exactly.
talk. Thanks, Sudhir.
Yeah, no problem.
So there's a question from Lou Coleman. Great talk. What thoughts do you have on taking care of the large number of childhood cancer survivors who have been exposed to anthracycline and chest radiation therapy, but yet have to manifest cardiovascular disease?
Oh, that's an excellent question. Yeah, so the adult childhood survivors, and so I think they do require routine surveillance. Specifically, I think they've got a double hit mechanism there, right? And so they've had typically high dose of anthracycline therapy. Subsequent to that, chest radiation, which can manifest in accelerated atherosclerosis and valvular disease. In the absence of symptoms, I think routine surveillance, and I think there's a paper that I read that I think every 3 to 5 years with an echocardiogram may be able to identify risk in this patient population as well, and having a reduced threshold for ischemic or anginal assessment and considering coronary CTA in that population as well. Certainly if they manifest symptoms.
So let me ask you something. Yeah, it seems that you're putting a lot of money on the imaging kind of markers. And I know you may or may not be familiar with some of the work that I'm doing with my colleagues in Colombia with Chagas, and as you know, there's a early cardiomyopathy or, an indeterminate state in which these people are infected but have not yet developed cardiomyopathy. So we've looked at some biomarkers in addition with GLS and other echocardiographic markers. And actually, if you do, this multivariate score using proBNP, high sensitivity troponin, galactin, you can actually identify the people that are going to progress to cardiomyopathy. Can something like that be done in trying to identify people that are going to develop this CTRCD?
I think so. I totally think so. So whether you're using novel applications like strain to do that, there's actually there's a machine learning. There's a paper actually published. I think it was within the last 2 years. I can't remember. I think it was in JACC. I'm pretty sure that looked at machine learning being able to predict phenotypes in heart failure patients. And so I think that machine learning would actually be a fantastic modality to identify those patients just based off of pipelines and the predictive models that are available. I think strain is possibly an option too, as you'd mentioned that maybe you guys are considering using strain. I think that the predictive benefit of AI is exceptional, and I think that that is probably a modality to be very helpful downstream for the ability to kind of predict and stratify individuals.
So you also mentioned something about, when you try to treat some of these patients, they get this severe immune inflammatory response also to treatment. So is there any chance that you can identify these and, pre-treatment with one of these new anti-inflammatory drugs, Cantus type thing?
It would mechanistically, it would make sense, right? And so if you can consider, it's also cost feasibility, right? So canakinumab is a very, very expensive drug. It's an IL-6 antagonist, but that's specifically IL-6, right? And so if you're thinking of clonal hematopoiesis of indeterminate potential, there's other pro-inflammatory cytokines that are involved in that immune-mediated response. Colchicine's cheap as dirt, like that's a possibility. But I mean, I don't think we have the understanding or the knowledge. It also depends of how early of an adopter you are. Like, even though we have a significant amount of data in terms of Colcott, Lodoca, Lodoca 2, there are going to be late adopters to the colchicine scene, even in cardiology, despite the mounting data that we have. I don't think we're there with colchicine or canakinumab in the cancer patient yet, though. But I do see, as you can see, the pathobiology mechanistically is we're there. We know that cardiovascular disease and cancer have an intersection for sure from a pro-inflammatory state.
Okay, Dr. Kavanagh has a question.
Morning, Sudhir.
Hey, how you doing?
Good, nice to see you.
Nice to see you as well.
My question is about strain. I realize you said there's a lot more work to do on it, but right now with what you're using, you mentioned a number of challenges. So how many patients, what percentage of the patients right now would you get a reliable strain measurement in the left ventricle? And then to take it further, if there's challenges with the left ventricle, I would assume that they're even greater with the right ventricle and the atrial analysis of strain?
Oh yeah, for sure. So RV strain, I'll talk about RV strain and then LA strain. Good time. Yeah. So RV strain is a challenge, and so ASC, God, sorry about that. ASC didn't you put it in their guidelines in 2010 because of variability in the not being able to identify. Sorry, I just put a timer for myself because I talk too much. Yeah, because so the RV strain wasn't included in the ASC guidelines in 2010, and because they couldn't find a nominal number for a threshold, basically. And so when you use RV strain, the RV free wall longitudinal strain is probably the metric that's best utilized. And if you understand that the limitation of global strain and assessment in the RV is that the interventricular septum is mostly, the deformation characteristics are mostly from the LV, not the RV at the level of septum. So you use the free wall. Obviously, contouring and being able to get a good apical view is of the RV itself is challenging. So there are challenges certainly with RV strain. Left atrial strain also has challenges if you think about the anatomy there. So we're looking at the pulmonary veins, the left atrial appendage, as well as the foramen ovale, all have reduced deformation really because of the anatomy, as well as you can have foreshortened images of the left atrium that also make it challenging. So you know, like there are limitations, and you can get it, and it depends on the ability of the sonographer to get the proper images. It also depends on, you know, the ability, like just really the images that you're able to obtain. But it's also, I think the onus is on the cardiologist and the echocardiographer to determine what is quality. Can you contour? If you can't, you got to say no, and you got to just you got to dump using strain. And I think that's probably the most important thing, is to really just say no and not use it. And I think that's actually quite challenging when there's expectations, and there will be expectations going forward that yes, we want to have RV strain, we want to have 3D RV echo done, but it has to be the right patient population. We have to determine the quality of the study, and the onus is on us to do it.
Okay, well, thanks, Sudhir. It was a fantastic presentation, and we will see you later.
Okay, thanks again. Take care, guys.